Okay, welcome back, everyone. Is that everyone hear me? All right. Too far away from the mic, not is it? Okay, great. Well, welcome back to the afternoon. I'm sorry I missed this morning. It sounded as if it was a fantastic morning of networking and great learning opportunity to find out what's going on in the centre. My name is Geoff Huggins. I'm Deputy Principal for Research here at Stirling. I get asked a lot to introduce speakers to share different things across the university, but I'm absolutely delighted today to be here because my home territory is really in ageing and dementia research, so it feels like I'm coming home to the gathering. But I'm really delighted to share this session and to introduce Geoff Huggins from Scottish Government. Geoff is Director of Health and Social Care Integration in Scottish Government. He's responsible for improving joint working and integration of health and social care. And I always think people in these positions must be polymaths because it's not just health and social care, it's housing, it's transport, it's the environment, it's everything that comes under health and social care label. So we're really delighted to have Geoff here. Prior to his work in health and social care, he was head of mental health and protection of rights division. He's worked across a variety of roles, again covering housing and education policy in Scotland, and politics and security with the Northern Ireland office, as well as being leader of the EU Joint Action on Dementia, so a real true polymath. How did you manage it, Roger? We're really pleased that he's going to be talking this afternoon about, or he tells me he's not going to be talking about this, but anyway, his title is Towards an Outcomes Approach to Measurement. And I know this is not just a Scottish issue, but also a global and particularly UK issue. We're very fortunate, of course, in Scotland to have a unique integrated health and social care system which has been looked at by and been the envy of many, many other countries. And we're delighted that Geoff's coming to talk to us about some of that today. I've also been asked to mention that we are now trending on Twitter. So any of you who want to contribute to that discussion, it's hashtag DARG17. That's right, is it, Emma? So tweet away, and we look forward to reading what Geoff's going to say on Twitter, as well as hearing. So Geoff, over to you.
Thank you. The last time I was trending on social media, I have to say it was Yammer, which I imagine for many of you is a network which you've never heard of, and which is only used, well, some of you clearly have, but trending on Yammer is not really quite the same as trending on Twitter. So I'm now going to disappoint you in two ways. The first is, as a consequence of foolishly agreeing to give a presentation last night, I appear now to have a cough, so I'm going to try not to cough my way through the presentation, but I may not succeed. The second way I'm going to disappoint you is that I guess normally you would expect somebody to come from what you might describe as the ministry and to tell you a story which has a beginning, middle and end, and a conclusion that you can all go away happy with at the end, or disappointed with, as you may see fit. In putting today's presentation together, I haven't really been able to achieve that. And I looked at the 12 or 13 slides that I've got, and I thought I could give these in a number of different orders. So I could start in one place, or I could start in a different place. And I guess what it suggested to me in terms of thinking about the different ways in which we approach measurement, how we understand the degree to which things are changing, the degree to which things are improving, the way in which we try and understand the world around us using numbers or evaluation, that we're doing that in a number of different ways in respect of both dementia and aging. So what my slides cover is a wee bit of context, a bit of history, and then a number of ways in which we're doing that, I guess, and showing perhaps within this a broader trend. And I think within that the trend, and I guess I'm giving away the end here at the beginning, which is probably not good. It's bit modern, but it is more of divergence and a broader span of different ways of understanding what is going on. I think quite often our approach and our objective is to narrow the focus into single indicators or single approaches or particular ways of understanding, but I think increasingly we've seen that's not helpful given the complexity of the world that we live in. So, context. I've been working on dementia policy in Scotland since around 2005. So I've been working on dementia since before it was trendy, and since before it was the weekly front page of the Daily Express, or it was will cure, will cause on a daily basis. And when I began, the first bit of work that came across my desk on dementia was the sign guideline on dementia. And at that point, when we thought about what was going on, our question was, are the clinicians doing what science says they should do when they see people at this stage of illness? And are they managing that? We had almost no data within the system about what was actually going on. And so our engagement process was largely through clinical guidelines to specialist clinicians about how they would work with people with dementia. If we look forward to 2008, 2009, 2010, we end up with national Scottish targets around increasing diagnosis rates, focus on diagnosis, what we call here is LDP standards, local delivery plans for boards standards, and then didn't make it onto 2012 post-diagnostic support, the rate at which we're actually meeting our commitments there. So we begin to measure at a national level the degree to which we're achieving particular political objectives, policy objectives. We believe dementia diagnosis is a constructive and positive thing, and on that basis, we'll track the degree to which we can increase the availability of diagnosis. Some of the context for this is the Scottish Government's National Performance Framework. This is the work that we did in 2007 to think very broadly about what the Scottish Government was achieving through its actions and those of its agencies and councils. And these broader objectives are around economic growth, are around the health and well-being of the population. And again, so at that macro level, we're seeing a connection to the ageing agenda. Fourth bullet down, we have the health and well-being outcomes, which we have 9, and I'll come on to those in a second, and the indicators that support integration, and they're beginning to become more fine-grained. So we see an approach which is increasingly looking at the quality of health and care systems and services from the perspective of the individual who's accessing those services. And just where we are at the moment, we're in the midst of a review of outcomes and indicators, targets and indicators, which has been taken forward by Sir Harry Burns on behalf of the Cabinet Secretary and Coswell. And I'll come back to that with the slide later on. So the health and well-being outcomes, we have 9 outcomes. These are statutory. These apply across all population groups which are served by integration, so they're not particular to dementia, although the significance of dementia within integration I don't think can be overstated. But you're beginning to see a move within this from targets such as 4RA&E to an understanding of the degree to which people are able to look after their own health. A question which is evaluative, which is about people's confidence, about people's capability. If we look further down, outcomes 3, people have positive experiences of the services that they receive, so that the experience of the service, in addition to the quality and clinical terms of the service is good. These outcomes, which are statutories, are supported by 2 sets of indicators. And this first group, and you don't need to be able to read them. If you're able to read them at the back, I think I would be adjusting your prescription. But this first group is largely about the experiential dimension. And at the moment, the way in which we would measure these are through the Scottish Health Survey. And again, a number of these, most of these will be very significant for the elderly population and for those with dementia. So, National Indicators 3, the percentage of adults supported at home, who agreed that they had a say in how their healthcare or support was provided. So an element there of engagement, and that idea of being tracked. Challenge with this data, one of the reasons why we are looking to review this as part of Sir Harry Byrne's review is we receive this from the Scottish Health Survey, which we do every 2 years. We can break it down broadly to local authority area in some areas a wee further, although we believe that most of the important business that we're trying to do is at lower levels of geography than that. But we only get the information and the data 18 months in arrears. So if you think that you're trying to understand what's going on within your system, you're looking a long way in the rear view mirror, particularly when you're asking integration partnerships, health boards, and councils to be changing services in real time. So only having data at that degree of lag doesn't support the sort of system that we're working with. The second group of indicators are more system focused, so they're thinking about activity and the dynamics within the system. And again, these are also, some of these probably are satisfactory, more of them are probably unsatisfactory. I think you had a presentation this morning on some of the 5 data in terms of the, from the previous work, which is, remind me, that was about 2011? Yeah. In terms of understanding. So this is again at population level, but it becomes very interesting when you begin to cut some of these indicators by particular diagnostic groups or by particular age groups. And I'll show you how we've done that in a second. But so, proportion of care services graded good, which is one of the only evaluative ones here. But the only indicator in this group that we have, which you might see as being a population health indicator, is premature mortality. So the only way in which we're actually understanding healthcare is how you're slowing down people dying more quickly in Scotland than in other places. So we're not really getting under the skin about trying to produce anticipatory or preventative strategies within Scotland. There's also duplication and probably too much of a focus between the interface between the hospital and the community.